So the start of the study asked a question that I didn't touch on very well just now, which is, are the genetic risks for the development of osteonecrosis in young children the same as those that are present in older children? And so like I mentioned, we know that there's a different rate of osteonecrosis in young children versus old. And so our first question was just, are these findings that we found in older children also true in younger children? And the answer to that is mostly no, but a little bit yes. So if we look at the individual variants in genes, those differ between older children and younger children. But what doesn't differ is actually the genes that we find some of these changes in. So as I mentioned, glutamate signaling seems to be important, and it was important in this very large study that involved primarily older children that we published earlier this year. And so this study also finds that variants in glutamate signaling are actually the most enriched population in these younger children as well. They're not in the same variants, but they're in the same genes or gene pathways. And so this is really interesting. It tells us that the therapy matters and age matters. And those two things go together to change which of these variants we find. But at the end of the day, what seems to really matter is the variants in these glutamate receptors, and that they seem to increase the risk of osteonecrosis. Younger children can get very similar therapy and have lower rates of osteonecrosis than older children. And actually, interestingly, adults who get ALL are lower risk of osteonecrosis than this magic age of 10 to 20. It's this sweet spot where the bones are still finishing up their development and seem to be very susceptible to therapy. So you're right, we have to be very careful for children that may have these variants. I think before we make changes to their treatment based on these variants, we need to do two things. The first is try to verify these findings either in our animal model or in an additional cohort of patients. And the second thing is to make sure that changes we would make to address this don't affect their sensitivity to therapy in terms of their cancer. So our hope would be that if we look at leukemic sensitivity to drugs in the same patient population, they'll be more sensitive to some of these same agents. And so that would give us the possibility then of decreasing drug exposure to patients that have these variants. Their leukemia will have inherited those variants, and so if the leukemia that inherits the variants is also more sensitive, then you could talk about backing off on therapy to decrease their risk of osteonecrosis. But above all, you don't want to decrease their excellent cure rates. Yeah, so the drugs that we think of most relative to these variants are steroids, and that includes both prednisone and dexamethasone, and then also asparaginase. And so in recent trials, because of both drug unavailability and because of better drug effect, we've used pegylated asparaginase. And so those will be the three drugs, but two classes of drugs that we would think of. First of all, I'd like to hear what others have in terms of their perspectives on our findings. It's interesting to get thoughts from other people who are here because they, are outside of our environment and they give us different thoughts and different ideas for ways to go forward. The other thing is that we're learning a lot about the biology of the disease leukemia more generally, and so the more we know about the biology of the cancer we're trying to treat, the better we can try to separate the toxicity to the patient from the toxicity to the cancer, which is what we're aiming for. So hopefully we'll learn more about disease biology that'll allow us to really separate toxicity from cure.